بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسوله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك أنت العليم الحكيم. My topic today is about the differential diagnosis of hypervascular focal liver lesion and clues for the diagnosis and with some examples. The common causes of hypervascular focal liver lesion include hepatic cavernous hemangioma, focal nodular hyperplasia, arterio-portal shunt, transient hepatic attenuation difference, THAD, Hepatocellular Carcinoma, Hepatic Metastases, and Hepatic Adenoma, and Hepatic AV Malformation, Osler-Weber-Window Syndrome. What are the keys of differential diagnostic issues? It is critical to characterize the morphology and hemodynamic of hepatic lesion to derive a specific diagnosis. Examples: cavernous hemangioma, arterio-portal shunting, AVM, isodens to the blood vessels in all phases of imaging. Focal nodular hyperplasia, nearly isodense or isointense to the liver non-enhanced study, portal venous and delayed phases. Homogeneously hyperdense on arterial phase. Hepatocellular carcinoma, hypodense to the liver on non-contrast, enhanced CT and portal venous phase and delayed phase imaging. Heterogeneous hyperdense on the arterial phase. Cholangiocarcinoma, hyperdense on non-contrast enhanced CT, hypo-iso or hyperdense on arterial phase, hyperdense on the delayed phase of imaging. Helpful clues for common diagnosis: hepatic cavernous hemangioma. Small capillary hemangioma may enhance quickly and homogeneously if it is small, less than about 1 to 1.5 centimeter. Enhanced portion of all hemangioma remain nearly isodense to the blood vessel on all phases of imaging CT and MRI, and this is very important. Nodular discontinuous peripheral enhancement with progressive centripetal filling in for larger hemangiomas. It is also very important to remember this. It is nodular discontinuous peripheral enhancement and filling in the delayed phase. We see here it is a small hemangioma, cavernous hemangioma or flash hemangioma, complete filling of the hemangioma in the arterial phase. Focal nodular hyperplasia, seen in about 2 to 5% among young women. Homogeneous bright enhancement on the arterial phase or enhancement. It is central scar seen in about 2/3 of the focal nodular hyperplasia phase more than 3 centimeter, nearly isodense or isointense to the normal liver or non-contrast enhanced CT or MRI, and it is also hypodense on portal and delayed images. Here we see arterial phase, large focal nodular hyperplasia with homogeneously enhanced with central scarp and noted here, and the draining vein on the periphery of the lesion. Another patient with focal nodular hyperplasia. Here, this is MRI study. Fat suppression T1 images shows bright enhancement in the arterial phase with central scarp, and on the portovenous phase seen in the isointends to the liver with central scarp. Arterio-Portal Shunt. It is common cause of small, usually peripheral hypervascular foci within the cirrhotic liver. Isodense or isointends to the liver, non-enhanced portal venous and delayed imaging may result from percutaneous biopsy or percutaneous catheter placement or other trauma. Look for early filling of portal and hepatic portal vein branch. Here we see arterio-portal shunt on axial CT scan in the arterial phase, and abnormal vessel noted on the left lobe of the liver with filling of the left portal vein due to arterio-portal shunting, and this result from biopsy with biopsy resulting in fistula in this patient. Transient hepatic attenuation difference. Third, peripheral wedge shaped hypervascular lesion seen in the arterial phase imaging, either CT or MRI. If it is an MRI, it is called third. Usually due to obstruction of the portal vein branch with compensatory increased arterial flow to the involved liver. Can you usually ignore small subcapsular region, larger or segmental third lesion, usually due to mass causing occlusion or compression of the portal vein branch, example metastasis, hepatocellular carcinoma, large benign mass or abscess, even sometimes come from the compression from the rib. As we see here in this patient, peripheral small wedge hypervascular lesion seen in the arterial phase of this patient with cirrhosis, typically third on or AB shunting lesion. Hepatocellular carcinoma, usually heterogeneous hyperdense on the arterial phase with washout and wash out to hypoattenuating on the portal and delayed vessels. Look for signs of cirrhosis and invasion of the portal vein and biliary ducts. Here we see large lesion in segment 6 of the liver, heterogeneous enhancement in the arterial phase with non-enhancing area, and it is washed out in the portovenous vase. Hepatic metastases, usually from the endocrine, primary melanoma or renal cell carcinoma, multiplicity, heterogeneity, ring enhancement, favor malignancy. Here we see two lesions involving the liver with hypervascular in the arterial phase and still hypervascular and still in the portal venous phase, and this is metastasis from the neuroendocrine tumor, isolated cell tumor, and you see here enlargement of the hepatic artery to the metastasized lesions. Hepatic adenoma, you seen in the young woman or patient with oral contraceptive or individual on anabolic steroids, usually heterogeneous hypervascular, often with foci of fat, necrosis, hemorrhage, more evident on MRI than on the CT scan. Here we see large lesion involving the right lobe of the liver with slightly dense area, suggestive of hemorrhage. After in the arterial phase, it is enhancing heterogeneously of this mass lesion. And on the delayed phase, there is washout of the with some area of still enhancing, probably due to hemorrhage. In this patient with hepatic adenoma. Hepatic AV malformation may be isolated abnormality, may be part of multi-organ fibrovascular dysplasia, hereditary hemorrhagic telangiectasia, Osler-Weber-Rendorf telangiectasis, and AVM in the liver and other organs, lungs, GI tract, brain, etc. Patient represent with nose bleeding, GI bleeding, and hemoptysis, liver, large hepatic arteries, and draining veins with vascular masses. Here we see axial CT scan on the arterial phase and enlarged feeding arteries and early filling of the hepatic vein in patient with Osler-Weber-Rendorf telangiectasia. Less common causes include nodular regenerative hyperplasia, Fibrolamellar Hepatocellular Carcinoma, superior vena cava obstruction, Cholangiocarcinoma, Peliosis Hepatis, and Angiosarcoma of the liver. Some clues for less common causes: nodular regenerative hyperplasia seen in the body cavity or congenital heart disease after Fontan operation. Large regenerative nodules are common, seen and usually multiple 1 to 3 centimeters, sometimes resemble FNH on the imaging and pathology even. Patients with Budd-Chiari also have hepatic and perihepatic venous collaterals that may appear as vascular lesions. Here we see in patient with Budd-Chiari syndrome with multiple regenerated hyperplastic nodule, hypervascular with ascites, and you see also the occluded IVC of this patient with collaterals. Fibrolamellar Hepatocellular Carcinoma, large heterogeneous tumor with calcification and metastasis, usually young patient. Here we see large mass involving the right lobe of the liver with calcification enhanced with heterogeneously with some necrosis, and the mass it is washed out in the portal venous veins, and also there is lymph node metastasis in the cardiophrenic area. Another patient with large mass with heterogeneously enhanced with necrosis and calcification involving in the and a washout in the portovenous phase. Superior vena cava obstruction. We have collateral veins running along the diaphragm may pass through the liver to the IVC. Broad area of hypervascularity in left lobe of the liver in the arterial phase, no mass effect. Here we see patient with superior vena cava obstruction with multiple collaterals in the noted here, and there is hypervascular mass lesion on the medial segment of the uh, of the of the of the left lobe of the liver. And on the delayed phase, we see the homogeneously enhanced liver with still see the collaterals on the abdominal wall. Cholangiocarcinoma, occasionally hypervascular, look for delayed persistent enhancement and capsular retraction, and it is not seen in the HCC. Peliosis Hepatis associated with the chronic wasting disease, and certain medication also in the Bartonella infection. Variable appearance sometimes resemble hemangioma. Here we see in this patient with Peliosis Hepatis, there is ring enhancement in the arterial phase, and it is more filling in the portovenous phase. But it is similar to cavernous hemangioma, but in the hemangioma it is nodular in appearance rather than complete ring in appearance. Angiosarcoma of the liver associated with industrial toxins, bizarre enhancement pattern may resemble hemangioma, and multiple lesions in the liver and the spleen. Here we see multiple lesions involving the liver with bicular eccentric enhancement as we seen in this lesions. Also another lesion on the spleen has the same characteristic of enhancement of the liver. Thank you very much for listening and hoping to see you soon in another presentation.